That's going to be discussed today, as it indicates on the flyer, is colorectal cancer, what we need to know, and who is at risk. But before I introduce the speaker, I would like to go through some rules and guidelines that will help us have an uninterrupted medical workshop. First of all, like I said earlier, please ensure that your devices are muted and to avoid interference or feedback. Okay, questions will come after the presentation, not during the presentation. So in other words, if you want to use if you want to ask a question, you can go to the chat room. There's a feature there where you can raise your hand. I'll be paying attention, and the audiences will be called upon according to the time that you raise your hand. Alternatively, if you don't feel comfortable to ask a question live, you can type your question privately to me, then I'll read it out to the speaker and he'll definitely attend to it. Finally, if you have any contributions based on the topics, you'll be allotted 2 minutes to do that. And that will be during the questions and answers session. So without wasting any much of your time, I'll thereby introduce the speaker. His name is Dr. Chinemerem Okwara. He's a gastroenterologist and an assistant professor at UT Southwestern, Dallas, Texas. Dr. Okwara, you have the floor now.
Thank you very much, Henry. And thanks to all the organizers for giving me the opportunity to talk about this topic, because I think it is important to talk about, since we are affected a little bit more than people of other races. Let me start by seeing if I can share my screen here. Okay. Okay, can you guys see the slide?
Yes.
Okay, all right. Okay, so we're going to be talking about colorectal cancer, and I'm hoping by the end of this presentation, everyone will have an idea of what colorectal cancer is, and some of the ways to try to decrease their risk or prevent its development. I'm used to giving a lot of presentations in the past. Usually I'm giving presentation to similar group of people. In this situation, I'm giving this presentation to an international group of people with various backgrounds. So that makes it difficult to focus the topic. The advice I have been given for this presentation is to present it as if I was talking to my patients. So in that sense, I will have a lot of information in the slides, but I will try to explain them as simply as possible as we go through this presentation. Okay. And Henry, just to check one more time, you guys are seeing the full slide, correct?
Yes. I don't know about, yes, I'm seeing the full slide.
Okay.
Yeah, man, we can see the black border and the next slide, so full screen it.
Okay, let me change what I'm sharing then. Let's share this one. How's that?
Okay, better.
Okay, thank you. All right, let's move forward. So to give you a roadmap of what we're going to be talking about today, I want to start by giving you an introduction about the anatomy that we're going to be discussing. I'll give some information about how colorectal cancer is affecting African Americans or Black people more than other people. And then I'll touch on some things that have been deemed to be risk factors for developing colon cancer, as well as some measures that might decrease your risk of developing colon cancer. Then I'll talk about screening modalities for colorectal cancer. I'll try to focus on the main ones that we utilize in the clinical setting. and I won't talk as much about those that are not really used too much these days. After that, I think everything before this red line are going to be the key topics of interest that are easy to digest for most people. After that, it could get a little bit more confusing, but again, I'll try to explain it as if I was talking to my patients in as simple of a manner as possible. Those that are more scientific might enjoy the details of it a little bit more, and this slide will be available for those that are interested after the presentation. I'll talk about the treatment at the end just to give you a broad sense of what happens once the diagnosis of colon cancer is made. I will have slides with lots of details again. I don't want you guys to get bogged down by the details of it. I'll try to summarize in the broadest sense what the management goals are usually, just to give you a sense of what happens after the diagnosis is made. All right. So to begin, colon cancer is the fourth most common diagnosed new internal cancer overall in the United States, behind prostate, breast, and lung cancer. And it is the third most common cause of cancer-related death in the United States. The incident rates are similar between men and women in the US, but worldwide there's a male predominance, meaning overall, globally, there's more men getting colon cancer than women. The lifetime risk of dying from colon cancer is about 2.5% in the United States. And globally, across the world, colon cancer is the third most common cancer in men and second most common cancer in women. If it is diagnosed at an early stage, the 5-year survival is pretty good, 90%. Unfortunately, only 40% of cases are diagnosed this early. And this is why it is important to screen if possible to catch more cases earlier rather than later. So this slide is meant to give you an overview of what we're talking about. When I talk about colon cancer, we're talking about cancer affecting the large intestine. The large intestine is the colon. So that's the area from where the appendix joins right here. This is called the cecum, all the way around to the rectum and the anus. So this is not involving the small intestines at all. We're talking about the large intestine. And in general, colon cancer begins as a mucosal lesion. We call it polyp. A mucosal growth, we call it polyp. And over time, as that polyp accumulates different mutations, it continues to grow in size and grows deeper. And that's what kind of escalates to colon cancer of various stages. And we can talk more about the different stages at the treatment slides. So this is also an important slide because I realized that not everyone might have access to some of the screening modalities we're going to be talking about later. So the question is, what are the symptoms of colon cancer? In a lot of cases, unfortunately, the colon cancer can grow without causing any symptoms until it gets to an advanced stage. In some cases, that colon cancer can ulcerate and cause bleeding. So if you see blood in your stool or clots that are coming out that's unexplained, that could be a sign of possible colon cancer, although there are many different things that can cause rectal bleeding, but that's one potential symptom of colon cancer. If you have access to laboratory studies, this can manifest as what we call iron deficiency anemia. Your hemoglobin is low because you're losing blood slowly in your stool. So that's one way you could potentially detect it without imaging studies or endoscopic studies earlier on. Another potential symptom of colon cancer is obstruction. As the mass grows, it can lead to occlusion of the colon lumen, decreasing the passage of stool that normally goes through the colon, and that can cause symptoms of obstruction. That obstruction can manifest as abdominal pain, distension of the abdomen, constipation type symptoms with characteristic pencil-thin stools, or small caliber stools, said another way. So in the next slide, I'm going to show an example. This is an endoscopic view of a colon where you can see this circumferential mass that's oozing or bleeding. So this is how colon cancer can cause rectal bleeding in some cases. And on this right side, this is basically an X-ray of the colon. It's likely a barium enema study. Down here is where the rectum is, sigmoid colon coming up here. And you can see basically white is the lumen of the colon. And you notice that in this area is very narrowed. So basically what this is demonstrating is mass that is decreasing the caliber of the lumen from this width right here down to what it is here. So this is how colon cancer can cause obstruction. That obstruction causes backup, which can lead to dilation of the proximal parts of the colon. Proximal meaning the area before the obstruction. So in this slide, I want to highlight again how Blacks are at higher risk for colon cancer. This is a worldwide study. It's not all inclusive because it doesn't have data from Nigeria, for example, but it does have worldwide data of different populations highlighting the incidence of colon cancer in men and women. And you can see in both cases, Blacks are at the very top, having the highest incidence of colon cancer in both men and women. So definitely Blacks are at higher risk for colon cancer. And this is another infographic depicting the death rates from colon cancer, comparing Blacks and whites. And you can see this is in male and female. This information is from 1975 all the way to 2016. Over time, you see that it seems that overall death rate from colon cancer is declining, probably because of screening, but there still is a clear separation between the death rates of Blacks. Blacks are red and whites are the gray color. So death rate is on this axis, time is in this axis. So you can see that Blacks, both male and female, have higher death rates compared to their white counterparts. So definitely higher risk. Another slide showing similar information. This is showing the incident rates on this side, and this is showing mortality again. This is data from 1975 to 2013. And again, you see a similar pattern. Blacks are green here, same over here, and then whites are blue. All other races are red. And you see the clear separation. Blacks have higher incidence of colon cancer and higher mortality from colon cancer. So we need to bridge this gap somehow, especially if it's something that we can modify. So as I mentioned before, overall, the colon cancer incidence and mortality does seem to be declining from those previous slides that I showed you, but Blacks continue to have higher incidence and mortality. And as I mentioned, the overall decline might be due to colon cancer screening, but likely Blacks are not having access to this screening like their white counterparts and people of other races. A population-based study that was done showed that patients under 50 with a diagnosis of colon cancer were more likely to be African-American or Blacks. So this information served as a guide towards starting colon cancer screening for Blacks at age 45 instead of 50 for the general population.
This cancer, this might be colorectal cancer. It is colon cancer. I kill this guy now.
Okay. I will continue for now. I don't know if that was a question or a comment, but I'll address it later if
No,
possible.
it wasn't a question. I think the person didn't mute their device, so you can go ahead.
Okay. All right. So now that I've shown you information showing that Blacks clearly have higher incidence and mortality of colon cancer, the question is, why is that? Okay. The answer is likely multifactorial. There are lifestyle factors that could be contributing, but I suspect a big reason is decreased screening in the Black population. Some lifestyle factors that contribute to increased risk of colon cancer are poor diet, obesity, decreased physical activity. So these are the things you want to make sure that you're modifying for yourself to decrease your risk of colon cancer. And the question is why, why may Black people have less screening compared to the white counterparts? There are multiple reasons for that. On the physician side, it might be that the physicians are not recommending it to their patients. In some healthcare systems, there's a backlog on colonoscopies. And so I know I've heard this mentioned that they're not screening Blacks at 45 because they haven't caught up on everyone else that's over the age of 50. So that is a potential contributor on the physician side. And then on the patient side, lack of knowledge of the need to get screened for colon cancer is likely a big contributor, which is why it's important to do presentations like this to inform African Americans about the need so that that is not a barrier. Lack of time is a factor. Some people are busy with work to make ends meet, so they don't have time to take off work to go seek healthcare to do screening. Cost of exams could be a prohibitive factor for patients pursuing screening. Fear of a diagnosis of cancer, general lack of interest in screening, and low perceived personal risk of colon cancer. That's basically saying, I don't think I'm gonna have colon cancer, so I'm not going to do it. So this is a table from a gastroenterology textbook that kind of highlights several factors that are thought to be probably or possibly causative and also protective. So on the left side, we're going to talk about some of the factors that I think could be probably causative. That's diet that's high in fat and low in fiber, and as well as red meat consumption. So this is telling you that you should try to minimize fatty foods, try to increase fiber in your diet, and try to limit your red meat consumption because these are probably causative for colon cancer. As far as the possibly causative factors, alcohol intake, may be a factor, particularly for rectal cancer. Cigarette smoking is likely a factor, and I personally think this is probably a significant factor. I do a lot of colonoscopies, and I tend to find that patients that are heavy smokers are more likely to have polyps than patients that are not smokers. So I think this is definitely a factor. Diabetes is thought to be a factor. There are some environmental carcinogens. Heterocyclic amines basically means they come from charbroiled and fried meat and fish. So if you like to grill, you should be careful not to burn it too much because that charred component can contain heterocyclic amines. Diet low in selenium, changes in the microbiome. On the protective side, there are some Medications and also some lifestyle factors that are here. Non-steroidal medications like aspirin, NSAIDs, and COX-2 inhibitors actually have robust evidence for having benefit for protecting against colon cancer. But you have to balance that with the risk of causing mucosal damage and GI bleeding. So this is not widely implemented that people take medications like aspirin or NSAIDs to decrease their colon cancer risk. But if it's someone that has cardiovascular disease or history of stroke, then taking that aspirin will potentially serve to be protective for their colon as well as their other systems. Calcium has been suggested to have some protective effect. Hormone replacement therapy, low body mass, vigorous physical activity are thought to be protective. So again, these are things that you have control over, maintaining a healthy weight, ensuring you're getting adequate exercise throughout the week. Other possibly protective factors include carotene-rich foods. So things like carrots, things that are colorful, vegetables, high fiber diet, vitamins, vegetables again, fish oil, statins, which are medications to help lower your cholesterol. So if you have cardiovascular disease again, and you have another reason to be taking the statin, then I would encourage it. So this is a table showing the degree or the level of evidence behind some of these possibly protective factors. And on the right side here are randomized human trials. So these are higher quality evidence. And on the left side, we have observational studies. So this is from looking at things that have already happened or things that are happening in animals. But randomized trials tend to be more robust and good evidence that something works. So on this side, you can see that the aspirin and NSAID have pretty robust evidence for their benefit in reducing the number of adenomas, their benefit in reducing the number of polyps. The same with the COX-2 inhibitor. For vitamin A, C, and E, there's a lot of observational studies showing some positive benefits and one evidence showing reduction in mucosal proliferation, which is a step towards development of colon cancer. Folate, a lot of observational studies with one data showing reduction in mucosal proliferation. Calcium, there's some evidence showing reduction in number of sporadic adenomas. And fiber, there's a lot of observational evidence for the benefit and one evidence regarding reduction in mucosal proliferation. And fish oil, there's some robust evidence for its benefit in decreasing mucosal proliferation as well as number of polyps. And again, statins also has some robust evidence as well. So the American Cancer Society provided some guidance regarding nutrition and physical activity to help with decreasing your risk of colon cancer. It is recommended to achieve and maintain a healthy weight throughout life, be as lean as possible, avoid excess weight gain at all ages, engage in regular physical activity, and limit consumption of high-calorie foods and beverages. It is recommended to consume a healthy diet with emphasis on plant sources, so vegetables and fruits daily, whole grain instead of refined grain products, limit consumption of processed and red meats, and then limit alcohol consumption, no more than 1 drink per day for women, no more than 2 per day for men. As far as exercise, it is recommended to engage in at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity physical activity each week. Children should also engage in exercise as well, limit sedentary behavior such as sitting, laying down, watching television, another form of screen-based entertainment, and perform intentional physical activity above usual activity to have the health benefits. So we've established that we do need to screen for colon cancer if possible, because we want to catch it at an early stage where the outcomes are better. For most average risk patients, meaning patients that don't have a family history of colon cancer or a family history of some genetic factor that increase their risk of colon cancer or some disease that increase their risk of colon cancer, screening usually begins at age 50. As I already mentioned in earlier slides, for African Americans and Blacks, it is recommended to start screening at age 45. And this age 50 has been kind of the age for starting screening in average risk patients for a long time. But recently, a couple of years ago, the American Cancer Society also suggested that everyone should get colon cancer screening starting at age 45. And this is because we're seeing a lot of young people getting diagnosed with colon cancer. Even though this recommendation stands and is valid to seek early colon cancer screening, the gastroenterology organizations have not quite fully adopted this recommendation to start at 45 for everyone. But that is a recommendation from the American Cancer Society. For patients that have a family history of colon cancer, they should start screening at age 40 or 10 years before the age that that family member was diagnosed, whichever one is sooner. And they should go no longer than 5 years in between their screening, even if they have a normal colonoscopy. This is assuming you're doing screening with colonoscopy, which you should be if you have a family history of colon cancer. So if you have a family history of a first degree relative with advanced adenomas, so a polyp more than 1 centimeter in size, you should also start screening at 40 or 10 years before that diagnosis because you're considered higher risk. There are some earlier starting times for screening for people that have genetic conditions, which I don't go into in this presentation just because genetic cancer syndromes are a big topic on their own. After the presentation, if there's someone that has a genetic cancer syndrome they're interested in, I can talk about that a little bit more. But for the sake of this presentation, I did not want to include all the genetic cancer syndromes. So how do you screen for colon cancer? There are multiple modalities for screening for colon cancer. On the left, I listed some non-invasive modalities, and on the right, we have the invasive modalities. On the non-invasive side, there are stool-based testing, there's imaging, and a new technology called capsule endoscopy is possible, but not really used too much right now. Under the stool-based testing, we have the guaiac FOBT. Basically, you're using a stool specimen to try to detect the heme in the stool. Beyond that, there's the FIT test, which is better than the FOBT because it's not just detecting heme, it's detecting human hemoglobin. And that makes it more specific when positive. There's the FIT DNA, which is the Cologuard. This is somewhat new test that people are getting now. And in addition to the detecting the human hemoglobin, like the FIT test, is also detecting some biomarkers that can be positive in the setting of cancer. For imaging studies, there's CT colonography, there's barium enema, which is not used too much these days, And then for invasive studies, there's colonoscopy and flexible sigmoidoscopy. Colonoscopy looks at the entire colon. Flexible sigmoidoscopy only looks at about half of the colon, so it's not going all the way. So I plan to talk more in detail about the FIT test, the FIT DNA test, slightly about the CT colonography, and then the colonoscopy. Since those are probably the key tests that are going to be available in most places, at least in the US right now. So the FIT, fecal immunochemical test, is a cancer detection test for average risk patients. That's important. If you have a family history of colon cancer, if you have a condition that increases your risk for colon cancer or a genetic cancer syndrome, you should not be getting the FIT test, you should be getting a colonoscopy. So for average risk patients, they can get the FIT test and it can be repeated annually if it's negative. It utilizes antibodies specific for human hemoglobin. That makes it specific and sensitive for bleeding lesions in the colon. A positive FIT test requires follow-up with the colonoscopy to try to find out what made the test positive. So this is a two-step test in that sense. If it's negative, you're fine, but if it's positive, you still need to have a colonoscopy to try to find out why it was positive. The next test, the Cologuard multi-targeted stool DNA testing, also for average risk patients, not for high risk patients. And as I mentioned, it's a combination of the FIT with testing for altered DNA biomarkers in cells that are shed into the stool. If it is negative, you can repeat this test every 3 years instead of every year like the FIT. And it has increased sensitivity, compared to the FIT testing, but also less specificity, meaning that you're going to get a lot more false positive tests that lead to colonoscopies. If this test is positive, you're going to need a colonoscopy to find out why it was positive. Okay, so I have a 3-minute video about the Cologuard, how to do the Cologuard test. So let me just quickly go to that right now. Yes. Okay. Can you guys see this screen with the video?
Yes.
Okay.
Yes, you can. Are we supposed to expect an audio?
Oh. Are you guys not hearing anything?
Not at all.
We are not hearing anything.
Maybe Dr. Okwara, what you can do is while the video is playing, you could do like a voiceover.
Okay.
Yeah.
That is unfortunate that there's no audio. Okay. I'm not sure how to share the audio, unfortunately, but I'll try to do some voiceovers when necessary.
Exactly. Just
yeah. Okay, let's keep going. Okay, so that's the kit. Okay, so it's saying open and unzip. Okay, pull out the contents. Okay. Step 1. The audio is not really necessary. Okay. So step 1, you have the bowel movement in the container. Stool preservative. So cover the stool with the stool preservative. Okay. Let me try one thing here to see if it by any chance improves the audio, because I would prefer that you guys can hear the next one that plays.
Nem, are you listening to us with headphones right now?
Yes.
Maybe if you disconnect the headphones and let the audio play out loud, it will re-enter your computer and we can hear.
Okay. I'll do that for the next one then. But basically, this video luckily is pretty straightforward. You set up the equipment, you have a bowel movement, you collect a piece of the stool with the equipment that they showed there, and then you soak the stool in the stool preservative and you send that back to the company. So we'll go ahead and go to the next slide, and I'll try to troubleshoot that next video so that it hopefully comes out better.
Before you go to the next slide, if you permit me, although
Yes.
I had my hand up, you could also share the link if it is possible with us in the chat room. So it will make life easier.
1 carrot order for bed 2.
To that PT? Can they do it over there? Can they order, put it on there? But okay.
Can you please mute? Okay. So moving forward, if you have any suggestions, you could send me a private chat so that I could relay to the speaker, please, to avoid any interruptions. So Dr. Okwara, maybe you could send the link to the private chat, to the chat room, then for later perusal. You're muted, Dr. Okwara.
I was saying you have the slide already, correct? You have my PowerPoint slides, Henry? Can you hear me? All right. I will just resume the presentation for now, just because I don't want to get too sidetracked. Henry has a copy of this PowerPoint slide. Perhaps you can help me with posting the link from there to the chat room while I move forward, if you don't mind. Okay. So that's the Cologuard feed DNA testing. And we just watched the video on how to perform the test. The next test I have a video for is CT colonography. This is also a test for average risk patients. It's an imaging study. And in addition to using this test for colon cancer screening, we as gastroenterologists use this test sometimes when we have difficulty getting through the entire colon for whatever reason. And it can help with detection of lesions more than 1 centimeter, which would be an advanced adenoma. It requires a bowel prep to clear out the colon so that they can see the mucosa well. And the CT scan is performed with the patient laying down on the left side. There's a 3D software that allows them to examine the colon, and any polyp or lesion greater than 1 centimeter that is detected requires colonoscopy for removal. The one good thing about this test is it does not require sedation. So if you're an average risk patient, this is a test that can be done without sedation in case you cannot take off work or you have to do other things that day. And I believe President Obama used this test while he was president because he probably did not want to go under sedation, because I think when you go under sedation as a president, you have to hand over power. So I think this test allowed him to get his colon cancer screening done without having to hand over power to his vice president or something like that. If it's negative or normal, it can be repeated every 5 years. So now let's try the second video, and I'll try taking off my my headphones to see if that makes this a little bit more smooth. So
let me suggest that the second video, we could just post the link to the chat room so people can watch it at their convenience, so you can go ahead with the presentation, if that's okay with you. Yeah. Okay.
If everyone is fine with that, then that's okay. I will want to show the colonoscopy video though, just because I think that would be good to see. But I'm okay with skipping the CT colonography video for now.
Yeah, that's fine.
All right.
No, please don't skip the video lecture. Give us.
What do you say, Henry?
Yeah, so I'm saying that I'm going to paste the link on the chat room so that they can watch it.
Okay.
So we don't have the same thing that happened with the previous video, battling with the audio.
Okay.
Yes.
All right. So colonoscopy is essentially the gold standard for colon cancer screening. It's not just a cancer detection test, it's also a cancer prevention test, because during the colonoscopy, if you find precancerous lesions like polyps, you can remove them and prevent them from growing into colon cancer. The test requires sedation, so the patient has to have a driver to take them to the appointment and bring them back home. They should not expect to do anything, make any big decisions that day or do anything that's complicated, because they would have been exposed to sedation. The test requires a bowel prep so that the colon mucosa is clean so that we can see any polyps that are in the colon. And as I mentioned, removal of precancerous polyps prevents colon cancer. And if the colonoscopy is normal and the prep quality is good, it's a high quality colonoscopy, the patient can have this done every 10 years. If the prep quality is not very good, meaning that we don't feel confident that we saw the entire colon mucosa, then that will likely shorten the interval from that 10 years, depending on how bad the prep is. If a patient has a family history of colon cancer, then they are coming back every 5 years instead of 10. And again, genetic conditions or cancer syndromes will have different screening intervals as well. The picture on the right is basically showing, let me go back one more slide. So usually the patient is laying down on their left side. There's a screen for us to see what's going on the inside. And there's an apparatus right here that allows us to maneuver the scope that's in the patient. And the goal is to get in through the rectum, go all the way around to the cecum. And once we get to the end, we look carefully as we come back and remove any polyps we see. And on the front end of the scope, at the very end right there, the scope has different channels. There's a channel that allows us to pass instruments to remove polyps. There's a light source, and there's an irrigation capability, as well as a video camera to project the image that we see onto the screen. And I do want to show this video because it will allow us to see an example of what a normal colon looks like, what a polyp looks like and when it's being removed, and also how large polyps can grow to in some cases. So if you don't mind, Henry, I'll put this one on. I'll take off my headphones to see if that improves the sound quality, and I'll play the video, okay?
Yes, that's fine, go ahead. So there's a separate button on the presenter screen that says share computer audio, Dr. Okwara. So do you see it? Maybe that way we can hear. Do you hear me? So check on your screen. You can see where it reads share computer audio.
And both identifying and removing precancerous.
Good.
Notably for this exam, we use what's called a colonoscope. A colonoscope is a flexible instrument in which we can use knobs to turn both left and right, up and down, in order to examine the entire colon. This device also has a camera and a light on the tip of it that allows us to more thoroughly examine the colon and also to take pictures. Now, albeit your colon is approximately 160 centimeters or 60 inches or 5 feet, depending on which measurement you use. But we do not need to use 5 feet of scope in order to examine the colon, because your colon is very compact inside of your abdomen. We're entering through the rectum. And as we move beyond the rectum into the sigmoid colon, our goal is to gradually reach the end of the colon, which is the ascending colon, and specifically the cecum. Now, the colon is not straight. In fact, there are a lot of twists and turns that you'll see as we move along this colon exam. instead of brown and solid stool. We are currently in the ascending colon and about to enter the cecum. And you'll notice you've reached the cecum by looking at the landmarks. What we're looking at there is called the appendiceal orifice. On the other side of this orifice is your appendix. Now let's look at a different patient. What you'll notice in this patient, as opposed to the last patient we saw, is that on withdrawal, we're encountering polyps. And so we're using different techniques by which to remove polyps. What you're seeing here is we're using a snare. Snare is a device that is like a wire or a lasso, if you will, in which we can put a loop around, wire the snare around a polyp and remove it, either using it cold or removing the polyp cold, or using heat or cautery by which to remove the polyp.
Yeah, the audio is gone.
As a reminder, polyps are ingrowths of tissue that potentially could lead to cancer. So if we find them in the colon, now you'll notice two very large polyps here, one at 12 o'clock and the other at about 6 o'clock. Before removing this large polyp, we chose to inject epinephrine to ensure that we minimize bleeding from removal of this large polyp. Then, similar to the smaller polyps, we snared the polyp, but in this case we chose to actually choke the polyp for a while until we saw a color change and were confident that indeed we choked off the blood supply to this polyp before removing it. Now this polyp was too large to be suctioned into the suction portion of the device, and so we actually had to remove that entire polyp from the colon, suctioning it into the device and then removing the colonoscope. Here you'll notice a very large colonic mass, and this is something that could not be removed endoscopically, and so we chose to use what's called a forceps device by which we can take biopsies.
Okay, we can't hear you. No. Still not back. Can you try to mute and unmute yourself? Let's see if it resets. Nothing.
Maybe turn off the computer audio.
Yeah, turn off the computer audio. No. Yes. No. Hey. Turn off the computer audio and We can't hear you.
Hello, hello, hello.
Yes, yes, you're back.
Okay, all right. Okay, sorry for that interruption. I thought it would be nice to see that video just because I know not everyone has an idea of what happens when we talk about the colonoscopy. But now that we've done that, let's move on and continue talking about the rest of the presentation. So this slide, I just wanted to highlight, again, the main test for colon cancer screening. For the stool-based test, again, FIT test is probably what I would say is the test of choice in this category. It has the right balance of sensitivity and specificity between these other ones. And I think is fairly affordable compared to some of the other tests down here. For the direct visualization test, the colonoscopy is the test of choice. It's been shown to improve mortality. And with this test, if you find something abnormal, you can address it at the same time. This is a table highlighting the sensitivity and specificity of different tests for detecting adenomas that are less than 5 millimeters in size, between 6 to 9 millimeters in size, greater than 10 millimeters in size, and then cancer. Sensitivity basically means if there is something abnormal in the colon, what are the chances that a specific test is going to find it? Specificity means if the test is positive, what are the chances that the test is really positive and it's not a false positive? So now that I've given you that background, the FIT test, fecal immunochemical test, has very high specificity of 95%. So if it's positive, you can believe it is positive. And it has a reasonable sensitivity for detecting cancer of about 70%. And it's not very good for adenomas, you know, in general. It's good for detecting cancer, but not very good for adenomas. The colonoscopy, however, has pretty good sensitivity and specificity for detecting both polyps and cancer. Specificity is about 90%. Sensitivity for cancer is 95%. Large adenomas, 95%. And even smaller ones, over 70%. So this is why colonoscopy is the gold standard. But if you wanted to screen for cancer, the stool test is not a bad option to utilize. This is from the multi-task force recommendation from the American College of Gastroenterology. They rank the different screening modalities in tiers. And you can see in tier 1, you have the colonoscopy or the annual FIT test. Under tier 2, you have the Cologuard testing and the colonography and flexible sigmoidoscopy. And below that, you have the capsule, which I decided not to discuss further, and this one that I didn't even mention at all. And the American College of Gastroenterology suggests that we begin screening African Americans at age 45, average risk non-African Americans at 50. So that concludes the screening portions, and now I'm going to move into the pathophysiology. As I alluded to in the beginning of the presentation, this could be the part of the presentation that could get confusing for some people, but some people might find it interesting to understand in a little bit the pathophysiology that leads to colon cancer. The cancer development is multi-stage. Usually begins with abnormal cell proliferation. Normally cells of the colon divide and proliferate at deeper levels. And this process is meant to replenish the natural sloughing of mucosa as stool passes through the colon. As the cells move up to the upper layers, they should have decreased proliferation. Proliferation means kind of dividing. They should have increased differentiation. Differentiation means that it becomes assigned to be a specific type of cell, whether it's just a cell that produces mucus or a cell that does transportation of nutrients. It has the fixed function, so it's not dividing too much anymore. And so this image is just showing the deeper levels where there's increased proliferation, and at the very top of the mucosa where cells can get sloughed off on a day-to-day basis. So colon cancer is usually associated with accumulation of genetic alterations, and that will occur at different stages as the polyp grows to eventually become colon cancer. And the genetic changes can be categorized into three major classes. Alterations in proto-oncogenes. These are genes that, if uncontrolled, leads to these are genes that, if they undergo a mutation that's activating, then the proliferative or pro-division pathway is basically unchecked. Loss of tumor suppressor genes. This is where the genes that are supposed to prevent uncontrolled cell division or uncontrolled cell growth lose their function. So you lose the controls when you lose the tumor suppressor gene. And then there are abnormalities in genes involved with DNA mismatch repair. As cells undergo normal division, mistakes can happen sometimes in the DNA, and those are meant to be fixed. But if the genes that are responsible for fixing those mistakes are abnormal, then that can increase your risk of progressing towards colon cancer. And this slide, again, as I mentioned earlier, this is where the presentation can get to be a little confusing, and I apologize. But the basic concept I want you to take away from this is the normal colon becomes hyperproliferative, leads to development of an adenoma and then cancer. And along that process, you have different mutations that are occurring at different steps that lead to development of colon cancer. So it's an accumulation of mutations over time that leads to cancer development. Some of these mutations here are associated with genetic cancer syndromes. Some of them can occur with sporadic colon cancer. And some of them typically occur early in the process, while others tend to occur later in the process. So this slide, there's a lot of information, but the takeaway I want you to understand from this is the development of colon cancer is stepwise from normal colon to hyperproliferative epithelium to development of an adenoma, which is the polyp, and then with more mutations that becomes colon cancer. And this slide is busy again. It lists some of the genes that were in the previous slides. And I'm just wanting to highlight that the KRAS, for example, is a proto-oncogene. When this is mutated, you end up having unregulated growth because the pathway for proliferation is activated further. And these other genes are tumor suppressor genes. They are usually supposed to keep growth in check, but when there's a mutation that causes them to not function like they're supposed to, you have increased growth. And then these are also DNA mismatch repair genes. So I breezed through that section quickly because I know that section can be easily confusing. And I think I got across the key points of that section to you guys. So now I want to talk about the management and treatment. And again, as we go through this section and upcoming slides, I'm going to try to highlight the overall way that colon cancer is managed because it can get complicated when you get to different situations or different circumstances. So the management of colon cancer depends on the stage of the tumor at diagnosis. Cross-sectional imaging like CT scans are usually used to evaluate the extent of the disease and help with staging. A lab test, carcinoembryonic antigen might be ordered as well, which can be elevated in the setting of colon cancer and can be useful after the cancer is treated to know if it's coming back. In general, surgical resection is the treatment of choice when the cancer is not metastatic. So when the cancer has not spread, surgery is the treatment of choice. And it can still be considered in the setting of metastasis, in situations where the patient might have obstructive symptoms or bleeding complications that need to be addressed by removing the primary tumor. To understand staging a little bit, I have this picture on the right. So this is a section of a colon, and this is one wall of the colon that's brought out here. This is the lumen of the colon. So on the top, you have the mucosal layer of the colon where polyps usually start growing. And then you have a muscularis mucosa level here. You have the submucosa, which is where you start to see the blood vessels and lymphatics. This layer is important because when the tumor grows into this layer, then the risk of spreading increases significantly. And then beyond that, you have the muscle layers. And if the tumor goes all the way through the wall of the colon, it can spread to the abdominal cavity and you can have peritoneal disease, as mentioned in some cases. This is another picture showing the stages of growth as the tumor grows deeper into the colon wall and gets involved with the lymphatic tissue. So lymph nodes are usually removed at the time of the surgery because the surgeon or the team that's treating the cancer wants to know whether the cancer has gone to the level of the lymph nodes. Okay, another busy slide here. This basically shows you how colon cancer is staged. And I want to try to simplify this as much as possible. So you have stage 0, 1, 2, 3, 4. In general, stages 0 to 2 are dealing with the tumor growing at the localized area and deeper into the wall of the colon. Stage 3 usually is when you get lymph node involvement of the tumor. And stage 4 is when there's evidence that the tumor has spread to a more distant site. And that might be the liver, that might be the lungs, or that might be some other area of the body that the tumor has been found. So this staging system is what allows the oncologists or the cancer doctors to determine the treatment of choice. And actually, it's a team that is involved with treating the colon cancer once we diagnose it, because you need a surgeon involved, you need an oncologist involved. In some cases, you need a radiation oncologist involved in case that is necessary. And this slide is meant to give a sense as to survival rates, depending on the stage at which the colon cancer is diagnosed. So if you're diagnosed at stage 1, at 5 years, you have about 74% chance of survival. Overall, this is your best chance of survival if you're diagnosed at an early stage. Stage 4 is when you have metastatic disease. You can see that the survival drops off very quickly as the years go by. So the more far out the more advanced your malignancy at the time of diagnosis, or the more advanced your cancer is at the time of diagnosis, the less your survival will be over time. And that kind of, if you look at all these numbers, there's kind of a linear relationship between the staging and the survival. Okay, this is the confusing slide, or the busy slide I warned you guys about earlier. But this is from the NCCN National Comprehensive Cancer Network. This is what cancer doctors or oncologists use when they're determining how to manage a patient's cancer. The key thing I want to repeat again, whenever possible, the treatment is to do surgery and remove the cancer with wide margins. And that if it's an early cancer, that gives you the best chance for survival. So whether obstructing or non-obstructing, if it's resectable, you always want to remove the tumor with surgery. That's what all this information is showing here. And when you do surgery, you want to remove lymph nodes in that area. I think they take potentially around 12, and they'll examine those at pathology to see if there's any evidence of cancer cells in those lymph nodes, because that can have implications as far as whether chemotherapy is needed or not. In cases where the cancer has grown so large and there's a lot of enlarged lymph nodes and it's really advanced, sometimes they might consider giving some chemotherapy before surgery to see if they can shrink the tumor and make for an easier surgery than if they went in straight when there's uncontrolled disease. And then I'll have other slides talking about what they will do depending on the pathology from the lymph node dissection, and also when they're suspected of proven metastatic disease. So to summarize this slide, whenever possible, the key is to resect the cancer or the tumor with wide margins and take the lymph nodes at that time. If it's too big, then chemotherapy may be considered. If it's unresectable, chemotherapy will also be considered. So once you've resected the tumor and you've removed the lymph nodes, that allows you to do the pathologic staging, which is the slide I showed earlier, going from 1 to 4. And this gives information about whether there's nodal involvement. For the early stages, usually once you've resected the tumor, you can observe the patient, and there's a surveillance intervals for colonoscopy that comes after that. In cases where the tumor is more advanced, you might consider chemotherapy, but usually once a lymph node is involved, they have to use chemotherapy in addition to surgery to decrease the risk of recurrence. So that's what this slide is saying. Earlier stages, you can observe after you've resected the tumor. More advanced stages without lymph node involvement, you can either observe or do chemotherapy in addition. Once the lymph nodes are involved, you have to do chemotherapy. When it's metastatic, you have to do chemotherapy. So, yeah. And then this is the guideline for when you have suspected or proven metastatic disease. This is where it becomes very complicated because once the tumor is metastatic, the chance for cure becomes more difficult because you can't just cut out the tumor and be done. You have to, then have discussions with the multidisciplinary team about how to approach surgery, whether it's a good idea to do surgery or not, whether to do chemotherapy, or whether palliative care is the way to go. So once it's stage 4, it becomes much more complicated and it's not a simple answer as far as what you do. So before I get to concluding thoughts, just to wrap up the treatment, the takeaway is if you get it early, if you catch it at an early stage when it's still localized, the treatment of choice is surgery. If you get involvement of the lymph nodes or if there's evidence of metastasis, then chemotherapy or radiation might be required at those later stages. So to conclude the presentation, individuals of African descent have higher incidence and mortality for colon cancer, as demonstrated in those earlier slides. This may be due to lifestyle factors, socioeconomic factors, and genetics, as well as decreased screening might also be playing a role. I think the screening is likely a big contributing factor in addition to lifestyle. Screening should be sought at age 45 for individuals of African descent without any other risk factors, meaning they don't have a genetic syndrome and they don't have family history. It might be earlier if that's the case. So if you have a family history of colon cancer, advanced polyps, or genetic cancer, then you're getting screened earlier at age 40 or 10 years before the diagnosis. If it's a genetic cancer syndrome, the screening intervals are a little different, much earlier. And I've discussed different ways for screening for colon cancer. And I know that the screening modalities I discussed might not be universally available for everyone. If you are in a location that allows you to get screening, the best screening option is the one that you're able to do. But if you don't have access to screening, what I would recommend is trying to live a healthy lifestyle, eating a diet rich in fruits and vegetables, limiting animal fat, especially red meat, and making sure that you're getting adequate exercise to maintain a good body weight, a healthy body weight. And so I've already spoken about all of this now. And so that's the end of the presentation. Chadwick Boseman, Black Panther, recently passed from colon cancer. He was still in his 40s. And so this was a really sobering event for young African Americans, that someone as strong as him, or at least strong appearing, could be taken by something like colon cancer. So thank you guys for the time. Thank you for putting up with the technical difficulties. And I hope you took away at least one thing from this presentation or learned something new that will hopefully help you going forward in life. Thank you.
Okay, thank you, Dr. Okwara, for that very informative session. I'm sure we all took away something from what you said. There are lots of questions who are pouring in, and I know even in the chat room, there's a few hands that are raised, and I think they have questions or contributions.
Okay.
I'll just take on, let me go to Dr. Nelly. Dr. Nelly, do you have a question?
Yes, I have a question and a comment.
Okay.
So I'll just give my quick question and my comments. My quick question is on the aspirin. Is it low dose or is there a dose recommendation? Because I know that low dose aspirin is generally recommended for people who are 40 years and over. Mm-hmm. And if the low dose is supposed to be less risk for bleeding and all that. So if there's no recommendation on that, then that would be, it's a good idea to know what the dose on that aspirin is.
Yeah. So,
I got it. Okay, well, you want to take it one at a time?
Yeah, I guess I can address it one at a time if that's okay.
Okay. Right.
Since I have the answer for that one. When I was reviewing the data on the aspirin, I did see that it was the low dose aspirin that was used. They mentioned 75 milligrams, and there was data for 81 milligrams aspirin. So it was the low dose. There was a different one that had the dose response curve. I'll have to look at my slides to see if I made a note on that, but the aspirin was the low dose aspirin.
Okay, so my next question was, in the past, they used to talk about processed foods contributing to colon cancer, and how preparing food from source, which means fresh vegetables and all that, not having the nitrites and nitrates and all that things there. So for those people back home, then that used to have, naturally well prepared foods and not the things you buy over the counter from the stores being one of the reasons why we had less of a problem. So that's still kind of obtained.
I think I agree with that, and the key thing that one key limitation of the data that I have is this is mostly, the Blacks in this study are mostly Western, United States Blacks. So we don't have data from Africa, or at least I don't have that in this presentation. Those that eat natural, organic, I'll take out the organic, those that eat naturally, as we did growing up in Nigeria, are likely going to decrease their risk a little bit compared to those that eat more processed foods, like the Westernized diet. Okay.
My last one is just a comment. There's more of a comment. I have had 2 colonoscopies, one without sedation, which I recommend for my enemies if you're going to get one, and then the one with sedation. I just want to implore people who are worried about getting the colonoscopy that if you are 50 years and above, you should try and get one. The bowel preparation, in my opinion, was the worst part of the whole episode, because you had to go and sit in the restroom to use to clean out your bowel. But nowadays, in the days of smartphone, you can take your smartphone into the restroom and then sit there and watch your movie. So for my colleagues that are on here and for everybody here, colonoscopy over here is readily available. Back home, it is probably not. But for back home, where we have stool tests and some other minor things that we can do to try and try and diagnose colorectal cancer, like abnormal weight loss and all that. But remember that you may not have any symptoms with colon cancer, and by the time you have symptoms, it might be too late. So if you fall into the category of those who need a colonoscopy, please go and get one. And if you're my enemy, please get one without sedation. Thank you. And I forgot to thank you very much for your awesome presentation, and I appreciate your effort and taking time to give us this lecture.
No problem. No problem.
Dr. Nelly, for your contributions. And the next person is Sylvester. Sylvester, do you have a question?
Hi, thank you, Dr. Chinemerem. This is very informative. My question is, I know somebody that has a long-time complaints of hemorrhoids and occasional constipation. So I don't know, the person is not here. So I'm just trying to think, the person is younger though, it's in the late 30s. So is he a candidate for colonoscopy or getting checked out for the colon cancer?
So the person has hemorrhoids, and are those hemorrhoids bleeding? Is that a problem?
Yeah, it bleeds. I mean, it comes and goes, it comes and goes. And then occasional constipation comes and goes too. It's been a long-standing complaint.
Okay. It depends on, where that person is and what resources are available. For hemorrhoids, the first thing we try to implement is, fiber supplementation. So I don't know what this person is using to try to manage the hemorrhoids, because if they optimize their fiber intake, which is also supposed to help with the constipation, fiber and water, and they're still having the problem, then that might be a reason to consider getting checked, especially if they continue to lose blood. And also, I would be curious to know if the amount of blood they're losing has reflected in their blood counts. So I would recommend that person really make sure that their diet has been optimized to increase fiber, and we'll see how that affects their constipation and their bleeding. That doesn't improve it, then it might be a reason to get checked out.
Okay, thank you.
Yeah.
Okay, thank you, Sylvester. The next person, Jeffrey Borgo, do you have a question?
Yes, I do. And I would like to thank you for such a wonderful presentation. And I would like to thank the organizers and contributors for bringing this topic up. So this is my, it's more of a question. And I also have a short comment. The question is, do you know any programs in place where we could go en masse and get this colorectal screening done? Keeping in mind the cost, you know, because I know it could be expensive. Thank you.
Yeah. I don't know of any program in place to get it in mass, but I know that there's campaigns to increase screening in the high-risk population and those that, you know, the American College of Gastroenterology is trying to increase screening in the general population. I think your first access is your primary care provider. I think if you don't have a family history of colon cancer or a family history of polyps, if you have access to it, a colonoscopy is the way to go if you're age 45 and above. If cost is an issue, you can, I think the FIT test is a reasonable one to start with if that's available to you. So it depends on where you are, but your primary care provider, if you have one, would be your first person of contact to help get you access to colon cancer screening.
Does that answer your question, Jeffrey?
Yes, thank you, Doc. Thank you.
Okay. So just to add to what Jeffrey asked, what is the availability of these kits, the Cologuard and all that? Or how available are they? How accessible are they to people?
In the United States, I think they are very accessible, very, very accessible. I can't speak to other places like Nigeria for sure. You know, for example, I'm not sure what the availability is like there, but on the cost spectrum, the stool-based testing are, I want to say, are very affordable compared to the colonoscopy or the imaging studies. So the Cologuard is a little bit more expensive than the FIT testing. I think the FIT is a good balance of cost, sensitivity, specificity that I want to think that should be, you know, hopefully accessible worldwide, but I don't know for certain what the availability is in Nigeria. If there's someone that's involved in the healthcare industry in Nigeria and they know the answer to that question, I'll be interested to hear. You know, this could be, if it turns out that it's not readily available, then perhaps this could lead to an initiative where we, you know, reach out to the company that helps with the testing to see if there's a way to make it more available. But I'm not sure what the situation in Nigeria is for the FIT testing.
Okay, thank you for that. Dr. Biozo.
Thank you very much. I have a question. I know when you talked about CEA, the carcinoma embryonic antigen. So can it be used for screening or is it just to monitor treatment?
I don't think it's good enough for screening because I don't think the specificity is very good. The best way to use it is usually when you make the diagnosis of colon cancer, it gives, you know, you get an idea of how elevated it is, and then you can check it as you treat the patient for the colon cancer. If the patient's levels normalize after the cancer is treated successfully, then you can use it in addition to the colonoscopy to give you a clue as to whether the patient might be having a recurrence of colon cancer down the line. I think that's where it's really useful for checking for recurrence, but not necessarily for screening. But I don't know that it is very specific enough to use for screening.
But if for some chance I happen to do it and it comes back positive, is that in case I do have?
Then depending on where you are, you might have to consider the colonoscopy, but hopefully it's been done in someone that is of an age where they're at risk for colon cancer. But I don't know 100% what the answer will be for that situation. If you happen to do it by chance and it's positive, my inclination is that then you might have to go do a colonoscopy to see if there's something growing. But I'm not sure how to use it in that setting.
Okay, Dr. Honorable. Dr. Honorable, okay.
Thank you very much, Dr. Okwara. This presentation has been quite edifying. I've just got two questions, really. Maybe the second one might be a little bit like a brainstorming. The first thing was, I mean, obviously it's in your data, there is a lot. I mean, what I saw from the initial slides, blacks are, high risk, and I could see that majority of the bars ended up at 35. I'm just wondering why, I mean, it's not necessarily yours, but why everyone's pushing towards 50 rather than 35, if the data actually, global data has, people from the age of 35 being at risk. And secondly, I mean, is there any room for a universality? Because I mean, here in the UK, they start at 60. And, so it seems as if it's just a different picture or different message is sent through. You want me to ask the second one, or do you want to take that first one?
Maybe I should take that. Maybe I should take that first one. So I think I know the slide you're talking about. And let's see if I can go back to it here. This one, right? Is this the slide you were talking about?
Yeah, yes, that one.
Okay. Yeah, this is talking about the incidence, but I don't think this axis is referring to age. So I don't think this is referring to age, this 35 here. It's just highlighting who has the highest incidence of colon cancer among the different populations that were surveyed. But I think as far as when to start screening for African Americans, the American College of Gastroenterology has recommended for African Americans to start at 45. And then the American Cancer Society has recommended everyone to start at 45 just because we're seeing more and more young people diagnosed with colon cancer. So I think, if you go to a doctor and say, I want a colonoscopy, there are different factors that come into play as to whether they agree to perform the procedure or not. We have to have a proper indication to do the procedure. Otherwise, here in the United States at least, the insurance companies won't reimburse it if they think it's an inappropriate procedure. So having guidelines like the American Cancer Society and American College of Gastroenterology recommend starting at 45, I think that equips you to be able to go and ask your provider for one, and being able to expect that you should be reasonably granted. And then I may have missed the second part about what you said. You said that in the UK, they start screening at 60.
Yes.
And, I don't know if that's due to limitation in resources. I think that plays a role in certain situations. I know that one of the local hospitals here, they have a backlog on patients that need to get screening colonoscopy. Another institution I was at, the VA system had a backlog of patients that need to get colonoscopy. So I think because of a limited resource, you know, they might not offer it readily to people that should get it at a certain age. So that comes into play in that slide where I mentioned that providers might not be recommending it to African Americans because, you know, the institution is not able to handle the workload perhaps. So that's why you might have to be an advocate for yourself and say, I'm 45, I would like to have a colonoscopy, or I would like to get my colon cancer screening done. And so I think you just have to be your own advocate, because the way a local institution manages their resources might not be what is ideal per guideline.
No, thank you. Just another comment to that, obviously in the UK, because they run a different kind of health provision, which is free at the point of service. So it's not really a resource issue. The thing is that you can actually order your kit to your home and then send it back without going to the hospital. The other thing is clearly that in the UK, they actually do ask for 2 yearly, you know, so invariably it's perennially-ish, not after 5 years like that was initially presented. Okay. Now, the second thing I wanted to say was, because I deal with the pediatric population, and I see a change, a paradigm shift in presentations. Most kids, which didn't usually, I mean, it doesn't usually come along the ethnicity that we do deal with, coming down with IBD. But we know that IBD is, you know, is a very, very, people with IBD have a huge risk to colonic cancer. Now, is there anything about surveillance for these children? Obviously, like you mentioned, that there is now a new incidence, a rising incidence in young adults. So is there something that is in place for children who are known to have IBD? Do they now have to wait to 40, or do they have to wait to 45?
So it's different for, as I mentioned in my presentation, for people that have predisposing conditions like inflammatory bowel disease or genetic cancer syndrome. So for inflammatory bowel disease that affects the colon and goes beyond the rectum, so it's not just proctitis, they have a good burden of colonic disease. In those patients, usually they start having colonoscopy for surveillance every 1 to 2 years at 8 years after their initial diagnosis. So if you diagnose them with inflammatory bowel disease affecting the colon now, 8 years after that, they should start getting surveillance colonoscopies every 1 to 2 years. So it's different for those group of people.
Thank you. That'll be all.
Yeah.
Okay. Thank you, Dr. Nrebe, for your contributions. Mr. Anayo.
Yeah, thank you, Dr. Chinemerem. I actually have this case actually hits on because my dad passed from colon cancer 2 years ago, and he died in Nigeria. And the reason I bring this up, I have 2 questions here, is how easy is it for doctors to identify these symptoms when a patient comes to them? My dad had a few that I can mention. He had this abnormal weight loss, and he had a lower abdominal pain. It was prolonged. He had this for about 3 years, and he had this increased bowel movements and a lot of constipation. And he met, I can tell you, a minimum of 10 doctors, different doctors in Nigeria.
How old was he?
He was 77 when he passed. Okay. So this would have started when he was probably when he was 74. About 3 years that he kept losing weight. He was, worrying us, but nobody could give us an idea of what was going on. And my dad is somebody that, when it comes to dieting, he is a high fiber diet proponent. That's all he eats. He works out very well, so he doesn't get sick, rarely. This was the major sickness he had, and he passed from it. So my first question is, how easy is it for an average medical doctor, trained no matter the climb, to see these symptoms and then with his age suggest a colonoscopy as just as a precaution to rule that out?
Okay, so when someone loses weight abnormally, unintentional weight loss, we usually take that seriously. And it does make us concerned for possible malignancy. A lot of times we'll do different things to evaluate that. It might be an upper endoscopy looking for gastric cancer. That's one that can cause you to lose a lot of weight. We might do a CT scan to look at the pancreas, make sure there's no lesions in the pancreas. And in some cases, also a colonoscopy at the same time as the upper endoscopy. In your dad's case, I know it's a different climate, as you said. The hope would have been to capture him with screening, if he was someone that was getting that done from age 45, 50, given his age. But I think of the symptoms you listed, the one that would have set off the alarm would have been the weight loss more than anything. Constipation, abdominal discomfort can be caused by a lot of different things, or those can go hand in hand. But the other risk factor for cancer in general that I didn't necessarily highlight in the presentation is age. As we get older, we are higher risk for different malignancies, regardless of genetic factors or dietary factors. So in an older patient that's losing a lot of weight, that would have been something to be concerned about. The other question is, did he have lab studies done? If he had lab studies, his hemoglobin would have been another possible clue, because I'm going to guess that he probably had something advanced enough to cause obstruction that caused all those symptoms. So in those cases, usually the blood count might be low from slow blood loss over time. So in my practice, when we see anemia that's unexplained, that's also a trigger to pursue endoscopic evaluation.
Okay, thank you very much for that. He had lots of lab tests, lots and lots of lab tests. Every doctor ordered one, but still they end up, prescribing Flagyl, like almost, it didn't make sense to me.
Yeah.
But as the case may be, my second question is, I know when you presented at the stages of the cancer, finally, when he was eventually diagnosed at a foreign clinic in an eastern part of Nigeria, the doctors said he was stage 4 cancer. And, it was almost at the back. He suggested chemotherapy and surgery, but wanted to do the surgery first. We had to seek a second opinion on the western side of Nigeria. And the doctors there, they were specialists, actually. That hospital is known for, employing a lot of these specialists, even from here in the United States. They immediately suggested surgery, right? And, embarked, I was doing mention of chemo, at each stage. And after the surgery, during the surgery, they realized, he got sepsis. The symptoms they were seeing was that he had sepsis, so he was, given a whole lot of antibiotics because he was having fevers, and shivering and all that kind of confusion. But they went straight to surgery. And after the surgery, a few days after that, he passed. So my question is, looking at your presentation, was that the best process? Or is that the best way to treat it? Or did they do it wrongly?
As I mentioned in my presentation, when it's stage 4 is usually metastatic. And when it's metastatic, it becomes really complicated because there are lots of different factors to take into consideration. Surgery, the people that ended up doing surgery may have decided to do surgery because they were concerned about the degree of obstruction. Maybe he had very distended proximal colon. I don't know what they saw that made them thought they needed to operate, or he was going to perforate, and that can also cause its own problem. So I don't know what they saw that led them to make their decision. But what I do know is that whether surgery is done or not for stage 4, he was going to require chemotherapy regardless, as part of the treatment if he made it out of surgery. But it sounds like he had infectious complication, which can happen with any surgery. Or maybe, I don't know if he had distended bowel from obstruction that was already necrosing. I don't know what they saw that led them to do surgery immediately. But there's a lot of factors that come into play at that point in time.
Appreciate your explanations. Thank you.
Mm-hmm.
So before I go to the next question, I still want to draw everybody's attention to the chat room. You can find videos and materials of this presentation on nasinternational.org and nasmedicalmission.org. So the video will be available there for free download, and everything that's been discussed here, you definitely see it on those websites. Okay, so Gift, are you there? Do you have a question?
Yes. Yes, I do. Thank you very much, Dr. Okwara. I really, really enjoyed your lecture, and you are very good at what you do. Thank you very much. This year has been a very challenging year for me, health-wise, my whole life. So, I can't remember ever spending a night in an hospital, but this year I've spent a total of 19 days in the hospital, starting from pneumonia. First of all, I had pneumonia. Then I got COVID. Then just like 4 weeks ago, I had a thyroid surgery. So, and I'm approaching my mid-40s now. So, it was always from time they tell us, from 40, you've done half of your lifespan, and all this stuff start going. So I would be direct with my question when it comes to this colon cancer stuff and all that, because I had a real cancer scare with my thyroid stuff. So it happened that I knew maybe like a year or two ago that the right side of my neck was a little bit swollen. So I went to the doctor, and what she said, I went to my primary care doctor. What she said was like, this could be your lymph node is swollen because it's fighting an infection, like just normal stuff. However, she said it's going to go down, that she did a blood work for me. My thyroid level were good. Everything was fine. She said, well, between 4 to 8 weeks is going to go back down and that. And I just forgot about it like that, So it now came after COVID, I now had to change my primary care doctor. So that was when I recovered from COVID, then my first doctor's appointment. So she walked and, she was checking me up and all that. She now said, what's this? Like, she now touched she saw me and said, man, said, this is not good. She don't like it, that I should go. So instantly she sent me for an ultrasound. So I went for the ultrasound, and she called me back in to explain the result. She said, they can see 2 masses on the right side of my thyroid, and she's not comfortable with it at all. It's too big. So she now referred me to an ENT to get a biopsy done, so they can know if there's malignancy or if it's just benign. So I went to the ENT, and he just instantly told me that the size of the mass beats every threshold for biopsy in America. They can't do a biopsy for this. That even the biopsy needle will be too small to check the whole mass. They see that normally they do biopsy for only a mass with like 4 centimeters, but I got 2 on my right side. One is 12 centimeters and one is 7.5. He says, so you just have to do a surgery. And in that this is where the scare came. He said, I should try to do it immediately because this mass is growing too big and it might block my airways and it might cause instant death. So that was I did the surgery. So this was where the problem came. I'm talking about the worry, because you were talking about this, doing a colonoscopy, checking things out. I would have died out of worry trying just the thought. Even the ENT told me that if it's cancerous, I have the easiest of cancers because a thyroid cancer is the easiest to manage. You'll just take off the old thyroid and I will just take thyroid pill for the rest of my life.
Mm-hmm.
But Dr. Okwara, that information almost killed me because I kept looking on Google, I kept checking stuff, and everything was very scary. So not to take too much of your time, my worry now is I've been living without those two big, dangerous masses for as long as I can, because what the doctor said, he said it must have taken nothing less than 10 years for them to have grown that big. So, and I had no problems, but when I went to check it out, I started having all the problems in this world. So my thing is, what are the assurances what are the means medically to keep your mind together when you have all this kind of colonoscopy, for example, and they have to give you a reason that something is not too good and all that? Because, like, I want to go with the layman's knowledge that what you don't know don't kill you.
Mm-hmm.
So in situations like this, how do we manage this information not to get too worried? Because when you worry, I lost 17 pounds out of worry before my surgery.
Mm-hmm.
So after my surgery, now I've gained back 9 pounds. So
okay, so your question is your question is how can we deal with the worrying? Okay,
how do we manage the worries about this
stuff? I think part of it is try to determine what the source of your worry is. Are you worried about the complication of the surgery? Are you worried about whether it's going to become cancer? Are you, if you can identify the root cause of your worry, sometimes you can't do much about it because we're humans, but if you can identify the root cause of your worry, maybe you can obtain information to help put that to ease. For example, if you're concerned about the complication of your surgery, you can ask the surgeon, what are the risks of this surgery, or what's the chances of those complications happening? And those information maybe, could help you get better perspective on what you're dealing with, and maybe that can help. But, we're humans and, sometimes we don't have full control over something like that. But in some cases, the right information can help put things in better perspective for you. And online can be very difficult to navigate. Even for me as a healthcare professional, I know how to navigate, the online space to find reputable sources of information that I want to use for making decisions. So if you're not sure of how to navigate that, then I would say make notes of your exact concerns and ask your healthcare professional to see if they can help provide you the right information to hopefully put your mind at ease if possible.
All right, thank you for that. Thank you. We have we're going to take one last question, but I want to remind us that we need to, you just have 2 minutes allotted time for your contributions or your comments, please. So let's just keep it that concise because this is the last question we're going to take before we round up. And that's going to be from Dr. Uche Guam. Dr. Uche.
Thank you very much. And please pardon me if I say something I'm not supposed to say, because I'm not a medical doctor. What I'm saying is that pardon my ignorance. I've been in the hospital in Cleveland Clinic since February this year. Mm-hmm. Battling spinal cord treatments. Spinal cord problems. Mm-hmm. You see, I'm wondering with the development of stem cell, the advancement of stem cell science, my understanding of stem cell is you use a workable stem cell, a very workable stem cell, replace it with the old or dead stem cell, isn't it? With that stem cell science not aid the colon cancer treatment?
I'm not a stem cell expert, but I'm trying to think of how it could play a role. I think my understanding of stem cells basic understanding is basically they are undifferentiated cells, meaning they haven't been assigned, you know, are you going to be a muscle cell? Are you going to be a nerve cell? Are you going to be a DAT cell? So they're undifferentiated. And so in certain situations, for example, where someone has nerve damage, they could try to use that to see if they can regrow that part of the nerve and restore function. That's kind of my basic understanding of stem cell. In the setting of a malignancy, I'm not sure how the stem cells would have any benefit because there's already uncontrolled growth due to some mutation, and you need to remove that uncontrolled growth and get rid of that from the system to treat it. So I'm not sure where the stem cells would assist in that process, but that could also be because I'm just not familiar with the science as much.
Okay. Thank you for that. Okay, we're going to take one last question from Ms. Chidema. Ms. Chidema, are you there?
Dr. Okwara, I have a couple questions, but I'll try and keep it short. My first question is, how young do you think is too young to seek a colonoscopy? Because with the recent stuff that happened with Chadwick Boseman, I've been seeing a lot of fear in like 30s, like people in their 30s and late 20s about possibly getting aggressive cancer at a young age.
Yeah. So in general, you know, for African Americans, I would say 45 is when you should start seeking, you know, colon cancer screening. Outside of that, then you just have to consider your risk factors. Modify your lifestyle risk factors that were discussed earlier in the presentation to decrease your risk as much as possible. Go to your regular doctor checkups with the regular routine labs. If you find something like anemia, then have that followed up, and that might be something that triggers you to get a colonoscopy. If you have a family history of polyps, that might be something that might get you an earlier screening at like 40. You know, if there's other things that can be considered too that might get you earlier colon cancer screening. So there are some genetic cancer syndromes that can cause cancers in other parts of the body, like uterine cancer, things like that can be associated with colon cancer in Lynch syndrome. So if you happen to know, you know, I have a family history of this aunt had uterine cancer, this aunt had ovarian cancer. If there's a lot of cancers in the family, you know, bring that up to your healthcare provider to see if that might paint a picture of a genetic syndrome that might need you to get checked out sooner rather than later, because, you know, that's something that is possible. But otherwise, you know, the average risk of African American, I would say, should seek screening at age 45. Besides that, modify their risk factors and go to their regular checkups. And if anything is abnormal, like the blood count is low, that's not well explained, that might be something to pursue further. Symptoms-wise, symptoms are not very specific, unfortunately. But if you ever have rectal bleeding that is not clearly hemorrhoids, then that might be a good enough reason to get a colonoscopy if you have rectal bleeding. That can be justifiable. Even in some cases where you think it's probably hemorrhoids, but it's been happening for a long time, it's not getting better, that might still be a good enough reason to get a colonoscopy too.
And then, with the colonoscopy, because I heard some concerns about the pain and the management. I know some clinics do anesthesia for colonoscopy and the patient is intubated and fully out. But I have seen examples of people just giving like sedation or like fentanyl or analgesics. Which one is more common, and how does that correlate to like the comfort of the patient? Like, is the patient always going to be comfortable no matter what?
It depends on what services are available at the institution that you're seeking the care. I've done the spectrum of patients. I've done colonoscopy on patients without sedation. I've done it on patients with moderate sedation, and I've done it with anesthesia. In general, we like to offer at least some degree of sedation for the patient to make the experience as, you know, as comfortable as possible. And the patients that have done the procedure on without sedation are usually patients that could not afford to be out of commission for that day. Say this person had a sick mother and no one else takes care of his mother. So he didn't want to be sedated and he had to drive, so he had to get it done without sedation. Or someone else, he didn't have any other family members. He couldn't get a transportation, any other means, and he wanted to do it without sedation. So I've been able, it can be uncomfortable in some patients, and different patients have different tolerance levels. The discomfort comes from distending the colon because we have to open up the colon to see where we're going. So that can be a source of some crampy discomfort. And there's some discomfort on the way in too, because as you saw from the pictures I showed earlier, the colon is not a straight shot. There are lots of turns to navigate. And as we're making our way through these turns, that can be a source of discomfort. In the patient that's unsedated, we take extra measures to decrease the things that can cause discomfort, using the least air necessary to see where we're going, reducing any loops that can form as you introduce the scope. I wouldn't advise it as the first option. If you have a transportation and there's no reason why you shouldn't get sedation, then I think you should get sedation, but it's not impossible to do without sedation. Because then you can actually watch what's happening live. If you don't get sedation, that's the one positive, and you'll be able to drive that day.
Okay.
On the next level from that, there's something we call moderate sedation. That's where you get a combination of medications that are meant to get you to a twilight state where, some people remain asleep, some people are kind of in and out. And that's it. That allows most people to be able to go through the procedure. And in most cases, they won't remember it because one of the medications, midazolam, is an amnestic agent, so they won't remember having the procedure done. But that level of sedation doesn't knock them out completely. They're supposed to still breathe on their own at that level of sedation. And I used that a lot, a year ago without any issues. With that level of sedation, different things can make it difficult to achieve adequate sedation. If the patient drinks a lot of alcohol, if the patient takes a lot of prescription pain medications or anxiety medications that already have sedating effects, then those patients might be more difficult to sedate with that level of sedation. And then the full spectrum with anesthesia. When anesthesia is present, they can do simple propofol sedation, which is similar to moderate sedation but stronger. And they can do the whole intubation if necessary, which is not necessarily always needed unless there's pulmonary risk factors that we're worried about in the patient. The vast majority of patients can get this procedure done with propofol or the moderate sedation, in my opinion.
Okay, thank you. You completely elucidated that for me. Real quick, whenever there's anesthesia or sedation, is there an anesthesiologist in the room, or do you handle the sedation as well?
So if it's propofol, there has to be an anesthesia provider, whether that be a nurse anesthetist or an anesthesiologist. If it's moderate sedation consisting of things like midazolam, fentanyl, Benadryl sometimes in addition, then that can be done with just me and my nurse who is trained in moderate sedation. And so the nurse will administer the medications either on my recommendation or based on the patient's response to the sedation. And we monitor the patient's vital signs to make sure that they are still breathing adequately and their blood pressure is also adequate.
Thank you.
Thank you. Sorry, we still have more questions. This is from Daniel Okenwo. Are you there?
Yes, I am.
Okay.
Yeah, Dr. Okwara, wonderful presentation. Very, very educative. My question is, this using a stool sample to test for colon cancer that is being flagged all over the place in United States. Is it really effective way to detect colon cancer at the early stage? If so, can one get a group or a community to do it as like awareness thing where everybody submits a sample and is sent to the center for analysis? That's my question.
Okay, so I went back to a slide that might help us answer this question. The fit testing or the different kinds of stool testing, in my opinion, the best balance is the fit testing. The color guide is also, okay as well. So the fit testing is able to detect colon cancer at a rate of over 70%, but it's not as good for the pre-cancer lesions, the adenomas of different sizes before they become cancer. So it's a good screening test, and it could detect it at an early stage, especially if the cancer is having some bleeding associated with it. But it's not 100%, it's not 100%. And it's better than nothing for sure.
Can I do a follow-up question, please?
Yes.
Oh, go ahead.
Okay. An organization like the National Association of Seadogs, can they say, okay, members of this organization in a particular town, city, or place on a certain day or week, bring in your samples, no questions asked, and then that kind of screening is done for them?
I think the way to consider doing something like that would be maybe working with an independent laboratory that can process it to see whether you can obtain the kit for doing the stool testing. Okay.
Right.
So if you discuss with the local laboratory, to figure out the logistics, then maybe they can make the kits available to you, and then the members can bring back the information. Because if a lot of people just bring in their specimens to one place, things can get confusing potentially. You don't want, the worst thing you want is confusion or mix up of one person's sample as some other, you don't want to get someone else's results. I just worry about the possible confusion, but I think if there was a way, I don't know for certain if there's a way to ask a local laboratory, can we get a bunch of kits, regardless of a physician's order, to just do for ourselves. If they're able to do that, then yes, you can organize something like this.
That answers my question, because if the kits are gotten and were properly labeled, there wouldn't be any mix up. Thank you very much.
Yes.
Just to be clear, just to be sure, are these kits or are they over the counter, or do you need a doctor's order for them?
He has answered the question. I think the thing is that in the case I am talking about, the organization or the group of people that want to do that will make contact with the laboratories. Like, for instance, in the United States, the Abbott laboratories that do it right now, which you don't need prescription to get if you want. But if we're doing it in a group or number, definitely there should be some other talking behind the scenes to get the logistics worked out. That's what I understood from what he said.
Okay. All right. So looks like we don't have any more questions. Dr. Okwara, I would say thank you very much for this opportunity. And on behalf of the National Association of Seadogs, and also the Longhorn Deck Dallas chapter, and every other person that is a member that's present here, I'll say thank you. I'm sure we took away a whole lot of information from this session. It was very, very informative, and I personally, I learned a lot, and I'm sure it's applicable to every other person that was on or is on. And just a reminder to every other person, these materials will be available on the websites, www.nasinternational.org and www.nasmedicalmission.org. Please endeavor to visit those websites, and you would see everything, both the recordings and the slides, they're all there. In the absence of any other questions or comments, I would like to bring this session to an end. And once more, I'll say thank you, Dr. Okwara, for this opportunity. It was very enlightening, and we are very grateful.
Thank you so much. It's my pleasure.
Appreciate you, Doc.
All right. So
thank you.
This brings the whole session to an end. So thank everybody for coming on, for logging on, and have a great weekend.
Thank you.
You too. Thank you.